Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi again. Welcome back to the Bridge to Health. My name is Dr. Tom Dow. And boy, let me tell you, have we been getting some response to our shows in the last few weeks. It seems like our guests have generated some real tremendous interest with you, the audience, and we appreciate your feedback. Today, we have a great guest and a friend of mine for many, many years, Dr. Richard Lendino. Hi, Dr. Lendino.
How are you?
Thanks for joining us today.
Thanks for having me today.
Dr. Lendino works in two of our offices, our Melville office and our Hicksville office, and also has his own private practice in his Hicksville office. And where is that located, Dr. Lendino?
It's on Old Country Road in Hicksville.
Old Country Road in Hicksville. And Dr. Lendino has been working with me probably for around 20 years,
20 years.
You know, treating patients as part of our treatment team. When did you first become a chiropractor, Dr. Lendino?
Approximately 21 years ago.
Okay, and you have a specialty. One of your specialties is chiropractic and sports injuries. Is that right?
Correct.
Cool. So, what is it that makes a chiropractor who treats sports injuries different from just a regular chiropractor?
Well, there's specific training, obviously, that we have to take so we can identify, particular sports injuries and the knowledge of athletes in general and the particular strains and stresses that they put on their body. With sports certification that we have, it was about 120 hours of
Classroom work?
Classroom work, correct. And then they had a completion exam. It was
Pretty intense.
yeah, it was about 12 hours, 12 hours every weekend or so for about 10 months.
Wow,
So,
that's pretty intense.
Yeah.
So, when a person has a sports injury, let's say they hurt their shoulder, and they go see a traditional orthopedist. The orthopedist has a little different of an approach than you would as a sports chiropractor, right?
Yes, we look at things a little bit differently.
Can you explain to the audience like what some of those differences would be?
Well, today with athletes, they have many, many health disciplines at their fingertips today, and they utilize all of them. They have the orthopedic, they have their regular medical doctor, they have their chiropractor. Today, strength and conditioning coaches are very big, acupuncturist, massage therapist. So as chiropractors, we are very concerned with joint function, okay?
Right.
Today, it's becoming more and more important for athletes. It's being more noticed, the important role that we play in sports injuries, because we are, looking at the joints and how prevalent spinal joint pain is with athletes today.
Right. So let's say an athlete injures their knee. I want to kind of try to get through to the audience our approach as chiropractors and sports chiropractors, and how it differs from just the average chiropractor approach and the average orthopedic approach. As I've told the audience many times, we work as a team.
Yes.
All of our team members are orthopedists, are neurologists, are chiropractors, are acupuncturists, and massage therapists. We triage the patient and we give them basically a la carte from the menu the best that each has to offer. So for instance, a typical ortho visit, an ortho will examine the patient's knee. He'll do some orthopedic tests to check for ligamentous instability, any indications for tears. He'll then take an x-ray usually of the joint. He'll see if there's any bone pathology. He may order an MRI, and then he makes a diagnosis of either what's torn, what's degenerated, and he will then institute a treatment of either physical therapy, injection therapy, or surgery. That pretty much sums it up, right?
Yeah. as far as the orthopedic goes.
Whereas you, as a sports chiropractor, you have to go through the same workup, make the same diagnosis, but isn't your approach a little more to, hey, let's try to find out what the cause is of why that knee went bad to begin with? Maybe their ilium's rotating. Maybe it's externally turning out their femur, which is that kind of what you do?
Yes, exactly. Because we're looking at not merely the area of complaint, but dysfunction of the entire body. Especially if we're talking about the knee, we want to look especially at the lower back in a patient. Because like you said, if the pelvis is rotated a certain way, it will actually, if the feet are pronated, in other words, if you have flat feet and they tend to tip in, that will cause rotation of the femur, which will rotate
the thigh bone,
the thigh bone or the upper leg bone, which will rotate the pelvis and will also rotate that last vertebrae in the low back.
Right. It's kind of like this. Your leg's on the ground. Your arch collapses. That causes the knee joint to rotate.
Yeah.
That now, over time, is going to hurt that knee joint.
Yes.
Where if that kind of situation exists, you just can't fix the knee.
Right.
You've got to fix the reason why below that happened to begin with. Is that correct?
Exactly.
Okay, and we sometimes work with orthotics in our office. We sometimes refer out to podiatrists to correct the foundation below. Because if we don't do that, what happens?
Then recurrent injuries.
Recurrent injury.
That's one of the things with chiropractic is that we want to prevent recurrent injuries. And with the athlete, a lot of these athletes, it helps them actually to increase their athletic performance to a better degree, because a lot of these injuries, when you speak of the knee, and you say, okay, it's a simple knee problem, maybe it seems like it's an acute problem, it happened during a particular motion or movement, but many of these injuries today are not just acute, they're overuse type injuries.
And it's kind of like, well, what caused that? What set that up to happen?
Exactly.
And many times we'll have patients come into our offices and they'll say, oh, I just bent down to pick up a paper clip and I felt a pop in my back.
Exactly.
How could picking up a paper clip hurt my back?
Right.
And we explain to them, it's kind of like the straw that broke the camel's back, no pun intended.
Yes.
But it's overuse, improper body mechanics,
Yes.
poor lifting technique, poor sitting posture over time
Yes.
that wears and tears an area that's unstable, and all it takes is one little more straw,
Right.
and then we have a big injury.
Especially when you have these 6'3", 240-pound patients that say, I went to bend over and pick up a pencil
Right.
and my back went down. Obviously, it's not the weight that's the problem.
Right.
It's the fact that something was going on, and like you say, that was the final thing, that particular motion, that set things off. Muscle imbalance, joint imbalance.
You know what I think is really amazing that when we learn that we've learned in our practices is that the worst hurt people usually aren't the ones that are big and strong and pick up heavy objects. It's the ones that have sedentary postures and sit all day.
Yes.
Their chairs are not the right height. Their heads are in the wrong position. Turn to the monitor to the right. The ergonomics aren't right. And it's that long-term, repetitive, poor biomechanics that causes more injury than lifting a 300-pound plate off the floor, right?
Yes. Well, whether it's trauma, as in like the athlete during the sports competition, or whether it's gravity's effect on your posture,
Right.
or whether it's many times work, the ergonomics of work, and sitting in a certain position. When you're more sedentary, there is no pumping of nutrients into certain areas of your body, especially the discs, to heal.
Right.
So, you know, as chiropractors, we believe after injuries that better to move as soon as possible, better to try and help that patient as soon as possible, not wait
Right.
for that scar tissue and stuff to settle in there,
Right.
but to get out of it as soon as possible. So that way, as the patient's moving about, there's a pumping of nutrients, things heal a lot quicker, and the patient has a much quicker speed of recovery.
So if you have a superior athlete, an Olympic athlete, a professional, even an amateur athlete, come into your office and they have a rotator cuff, and I want you to explain to us a little bit about what a rotator cuff is, what the injury is, but they have a shoulder injury, or let's say they have a knee injury.
Right.
And you also find that they have bones at a place in their pelvis, which is rotating their thigh bone, causing stress on the knee. You also find they have a fallen arch in their foot on that side, which is causing more rotation in the knee. And if that patient just goes and just has the knee taken care of and their pain goes away, what's going to happen to that patient the next time they have a big stress on that knee?
Right, there's a predisposition for
They're set up for injury,
another
right?
injury, another injury.
Right. And that reminds me of a story which I told on our first show, which I'm going to repeat now, which kind of really highlights and explains what we're talking about. I became a doctor of chiropractic by accident. I was a high school teacher for 2 years teaching sciences, and one of my colleagues noticed I was limping around one day because I had injured my knee playing football. He then said, "Why don't you go to a chiropractor?" I said, "Chiropractor? I thought chiropractors were just spine doctors." And he said, "No, chiropractors take care of everything." So I started to educate myself. I then went to visit a chiropractor who did a spinal exam on me and found in my lower back my sacrum, my ilium, my lower lumbar spine were in the wrong position, putting pressure on nerves going to the muscles that support my left knee. I already had 2 surgeries on my left knee, which didn't work. The knee was still unstable. The chiropractor went on to explain to me that 80 to 90% of the support of your knee is muscle, only 10 to 20% is ligament and cartilage. So he said, you need to get the nerve flow back from your spine to your knee so the muscles can get the messages they're supposed to from your brain without any interference, and then those muscles will be able to support the knee better. So I underwent a period of chiropractic treatment. Little by little by little, my knee started to get stronger. I was able to return to competitive sports. And this is a patient, myself, who never had back pain. It was a distortional problem that was found as the cause to why my knee was set up to be injured continually, over and over again. Right. So that kind of explains the difference between how you as a sports chiropractor are going to handle a patient. And in a minute, we'll talk about how you as a sports chiropractor, how your treatment differs in the work you do in that joint than other doctors. Dr. Landino, would you first kind of like give our audience a little education as to what, we'll talk about the shoulder first, as to what the shoulder joint is and a little bit about the anatomy about it, what a rotator cuff is and how it works. You were an anatomy professor in where, a massage school or something?
Yeah, in the College of Health Professions, I taught myology, which is a study of muscles 1 and 2, which is pretty much all the muscles of the body, their origins, insertions, nerve supplies, and actions and functions.
Right, and that's additional training on top of your sports injury training.
Correct.
So can you kind of grab one of these models and just explain to the audience what they're looking at?
Sure. This would be a model of the shoulder. The shoulder you can't really see from this model, but if you can picture, I know there's a lot of golfers out there, if you could picture a golf ball on a tee, that is pretty much what the shoulder joint is. It's called a ball and socket joint because the head of the humerus, or the upper arm, is ball-shaped. The shoulder blade, or the scapula, where the ball of the humerus, the head of the humerus goes into, is very, very shallow and small compared to the head of the humerus. So if you could picture a golf ball sitting on a tee, it looks very unstable in that position that the shoulder could, even maintain without, just falling down and falling out of the position. But the muscles themselves and the capsule, what's called the capsule, give it its greatest stability, okay? The capsule is something that surrounds the entire head of the humerus into that shallow socket, okay? Then you have what's called a labrum. Some people have injured their labrums in their shoulder or in their hips. What that does is it's another additional piece of the capsule that what it does is it fits around like this and it deepens the socket somewhat to give it a little more stability. Then you have this muscular component. The rotator cuff is composed of 4 muscles, okay? There is one in the front called the subscapularis muscle, and then there are 3 in the back. There's a supraspinatus muscle, an infraspinatus muscle, and a teres minor muscle. Then you also have additional muscles which also help to stabilize the shoulder, like the upper trapezius muscle. Then you have the deltoid, which are the shoulder muscles. So all these muscles stabilize the shoulder, and they're acting in different directions to keep it balanced. Basically, when it comes to the body in general, alignment and balance are the key. And in the shoulder, many times, it's the most dislocated joint of the body, and 97% of the time, it will go forward out of position because the muscles in the front, the chest, the lats, even though they're a posterior muscle in the back, they also connect to the arm and they draw the shoulder in. So those very strong muscles are trying to pull it forward and in, while these weaker, smaller muscles in the back are trying to pull it back and keep it a little more stable. So because you have so much freedom of motion with the shoulder in general, you have to sacrifice stability. So that's why the shoulder joint is injured so many times. And just another point, as Dr. Dow was saying, when it comes to the neck, what is the relation between the neck and the shoulder? Many times in the neck, Dr. Dow, what would you say, what area? There are 7 vertebrae in the neck with discs in between, all but the top 2. Which area in the neck, which disc gets injured the most often, would you say?
C5-6.
And which are the nerves that go to the shoulder?
C5-6.
Right. So many times there is some type of degenerative type condition going on, even with some of these younger athletes, where it can cause some dysfunction with the shoulder joint in general.
Yeah. And what that means, just so the audience understands, is the nerve roots which come out the bottom part of the neck, the 5th and 6th cervical nerve roots, they go and they feed these muscles in the shoulder and cause them to be either strong or weak. So if there's compression of a nerve in the neck because a person has a bone out of place pressing on that nerve, that shoulder muscle is not getting the proper messages that it should to support that shoulder.
Correct. Also, the muscles have receptors in them for length.
Right.
And if for any reason that muscle is shortened, it will
Right.
send a message back to the brain, which will then send a message back down to that muscle and keep it in that shortened position.
Exactly. And what we explain to our patients, I think you'll agree, is that when you have a joint that has 4 muscles supporting it, in order to go through certain movements, certain muscles have to contract out of those 4, and the others have to relax. We call them antagonistic and agonistic muscles.
Right.
One relaxes while the other contracts. To go the other direction, then it's the opposite. That one contracts and the other relaxes.
Right.
That allows smooth motion in the joint. And if the brain is blocked at the neck from giving signals to one of those muscles, you might have a situation where one muscle contracts and the other one doesn't relax.
Right.
And now instead of the joint moving very smoothly, it kind of like, it's ratchety because it's not coordinated well from the brain to the spine to that joint. Do you agree?
Yes, definitely. And there's one more point that I should make. When we talked about the ball and socket joint, or that golf ball on a tee, that motion is very important, but it has to be understood that the shoulder blade itself, which sits on the back of your thorax here, contributes about 1/3 to all that motion. And it's not a true joint, it's just held there by muscle.
Right.
If those muscles are tightened due to imbalance, that will also affect the range of motion in the shoulder, not just from the joint itself.
Right. So in a little while, we're going to talk about how we diagnose shoulder problems as a sports chiropractor, the different types of shoulder problems there are. But one of the things I've always found very fascinating, after even still being in practice 32 years, is we can actually test to see if a nerve in the spine is affecting a muscle. And we do that with a technique called applied kinesiology or muscle testing. We can actually, if we palpate an area in the spine and feel that a bone might be out of place, affecting a nerve going to one side of the body, we can actually test the strength of that muscle on one side of the body. Then we can kind of challenge and push that vertebra a little more to see if it's hitting that nerve, affecting that shoulder. And if it is, that muscle will become weak after we push in that vertebra. It's kind of like this. If I palpate Dr. Landino's neck, I do a muscle test on him first. This is a middle deltoid muscle. Hold. I ask the patient to hold. We'll see how strong he is. We just push him to the point where we know that's enough to get a feel of how much pressure that takes. We'll then take a vertebra we think's out of place, give it a little push, ask him to hold again, and if that nerve is being pinched, that muscle will go right down. Only briefly for a second, and then it recovers and comes back. But it's a way, one of the many ways, to help diagnose differentially whether it's a shoulder problem, whether it's a neck problem, or whether it's a combination of both. Because I think we have found, after many years of practice, I think you'll agree, that most of the time when somebody has a shoulder problem, they have a neck problem along with it. Do you agree?
If not all the time.
Most of the time.
Yeah.
Whether what came first, the chicken or the egg, we don't know. Did the neck cause a shoulder problem? Did the shoulder problem cause a neck problem? It's really irrelevant. What's relevant is that we identify where all the problems are, not just be a specialist on one joint and focus on that, but as a total, treat the whole body team doctor, look at the whole person and try to correct the cause as well as treat the acute problem. Would you agree?
Yes, definitely.
Okay. So, how does chiropractic, actually I'm not going to ask that question. Let's talk about different types of shoulder injuries first.
Okay.
So we have the most common word that most people hear are rotator cuff injuries.
Right.
What are they?
The ones that we see in our office most of the time, muscle strains, trigger points in the muscle. A strain is kind of when a muscle is pulled. I guess one of the best ways to, even though we're talking about the shoulder, if you were to see someone running around the bases during baseball and they pull their hamstring muscle, it's always in what they call the eccentric part, when the muscle is stretched the most.
Right.
Okay? So that's something where you might have some minor tearing of the muscle.
That's a strain.
That's a strain.
Right. So a strain is a muscle.
Correct. Strain is a muscle. Then we have things like bursitis. Bursitis, patients always, I have bursitis in my shoulder.
Right.
Bursitis is always secondary to tendinitis.
Right.
So there is another underlying cause going on.
Right.
The tendons of the muscle,
Right.
whether it's, again, acute or an overuse, which is becoming more and more common,
Right.
can irritate that bursa and inflame that bursa.
And there's all different grades or severities of strains, right?
Sure.
From grade 1, 2, 3, 4.
Yes, correct.
4 being the most,
Yes.
where sometimes that muscle is strained so bad that the fibers actually rip and the
Yes.
person might need surgery.
Correct, yeah.
Jose Reyes is a perfect example.
Yeah.
For the Mets, he used to play for the Mets. I forget who he plays for now. Lightning fast, and I think we find that a lot of these athletes who are really, really fast, they're pushing it to the limit.
Yes.
And that when that leg is out as far as it can go, and that hamstring is totally stretched out to its
Yes.
max, that's when they're most vulnerable, right?
That's when it is. And also, just one more thing when it comes to shoulder injuries, another common one is frozen shoulder, which you'll see a lot.
Tell the audience what that is.
Frozen shoulder, many times, gets to the point where if usually there's an underlying injury to that to begin with, the patient will try to, if it hurts to lift the arm, the patient will not lift the arm. If it hurts to do certain things, they will tend to, baby it, keep it closer to their side. The problem is when there's an injury, there is scar tissue. Now, when people think of scar tissue, you're always thinking about an operation. Scar tissue is laid down in the body when there is inflammation. If there is an imbalance, misalignment in the body, scar tissue is laid down, and then what happens is it gets harder and harder to break up. And many times it'll form right in the joint itself.
It locks the joint up,
It
so
locks
it can't
the
move.
joint, yes, yes.
Even if you're in the office and you're asking the patient to relax and you try to move that joint, it's hard to move. It's like glued, right?
It's incredibly painful to the patient, and there's a whole cascade of things again.
Right.
When one thing happens, it sets off a stage of a lot of other things that happen.
Right.
You get cross-linkage, which means a lot of these soft tissue tend to bind together now.
Right.
Because water is released when the joint is not moving as much.
Right.
And, these are some of the more common things that we see in the office as far as shoulders.
So why don't you tell the audience what you do, and you just recently got certified to do,
Yeah.
when you have a situation when somebody has a frozen neck, they're not moving well, a frozen lumbar spine, where they have very limited motion, or any other frozen joint.
Right.
What do you just get certified to do, and how do you handle that?
Right. Well, as far as chiropractors, we realign or adjust not just vertebrae in the spine, but also a lot of the other joints in the body. When there is an adjustment, it causes a quick breakage of a lot of that scar tissue so that the alignment is set. Then some of those muscles have to be stretched and lengthened. and the body has to be balanced again.
Thank you, thank you. On the next show, following this show, we're going to come back and we're going to have you talk about stretching under sedation for that condition, which is something when all else fails that we do. We're going to talk about that more. I'd like to thank you very much, Dr. Lendino, for being our guest.
Thank you so much.
I'm sure the audience was very informed. And for those of you who are watching us on Madhousetv, stay tuned. We will be right back. For those of you who are watching us on Cablevision, we'll see you next time. And remember, if what you're interested in is real wealth, wealth is not always about money. Come join us next time and let us help you cross the bridge to health. Thank you.
You're watching Madhousetv.com.
From Barton Home in Northport Village, I'm Erica Conway, and you're watching MadhouseTV.com.
Finally, the time has come. You no longer have to choose between conventional medicine and alternative medicine. Today, unlike years past, your team of doctors from all disciplines are working together side by side for the benefit of you, the patient, to help you regain your health and cross the bridge.
Hi, welcome back to the Bridge to Health. My name is Dr. Tom Dow, and we have Dr. Richard Lendino, sports chiropractor, back with us today for the next show. And welcome back, Dr. Lendino.
Thank you.
Okay. So in our last show, basically, Dr. Lendino, he spoke about different types of injuries that sports chiropractors take care of, and we left off with a shoulder injury and a condition called frozen shoulder. Dr. Lendino, so if a patient has tried physical therapy, if a patient has tried injection therapy, if a patient even has had surgery, and they still cannot move their shoulder due to scar tissue and adhesions that are built up in that shoulder, what else is it that we do in our office at times that may benefit that patient?
At times, in certain patients that don't respond, or I've had patients myself that are in so much pain that you can only get so much work done. Even lifting the shoulder this far is excruciating to them. So there's something called manipulation under anesthesia or stretching under sedation, where, you know, we're able to, you know, get a lot more motion into that arm and get rid of a lot of that scar tissue, where we wouldn't be able to with the patient, you know, cognizant of what's going on, because it's just too painful for them.
Right. So when they're sedated, there's no resistance to any motion that you have in that shoulder, and they feel no pain, correct?
They feel no pain.
So we've had many patients in our office where, I mean, they're totally frozen, where their arm is stuck on their side, and as much as we try, we might only be able to get their shoulder up to this point,
Right.
which it causes them a lot of pain. And the only way that we're going to get that shoulder working again is to release that scar tissue around the joint, which is formed. And we do that in an ambulatory surgical center with board-certified anesthesiologists who monitor the patient. And the patient has to be medically cleared just like any other surgical procedure to make sure they're okay for anesthesia. And then we go in there, and how long does it take normally when you do an MUA procedure on a patient?
Procedure, 10, 15 minutes usually.
Right, and it's not just for shoulder, right?
No, it can be for any part of the spine. Adhesions can develop in any part of the body, really.
How successful have MUA practitioners been with this procedure?
Very, very successful from what I've seen.
Okay. Are professional athletes utilizing sports chiropractors today?
I would say the great majority of them, sure. Professional athletes.
Give us some examples of athletes that utilize sports chiropractors.
It's endless, really, but I could say Joe Montana, Tom Brady, Arnold Schwarzenegger, Tiger Woods, Michael Jordan, to name a few. But as elite athletes, especially in the Olympics, when you think about how much a tenth of a second means to winning a gold medal or not winning, they want to utilize anything that will give them an edge,
right.
Anything that will help them recover faster,
right.
Have better function, and also to enhance their performance naturally.
Right.
So, they all, I would say all, but the great majority. It's hard to find too many athletes that don't utilize chiropractic services.
So I think basically what you're saying is that if you can make a correction structurally in that athlete,
Right.
whether it's in his shoulder, whether it's in his neck, whether it's in his back, whether it's in his knee, that gives them better normal structural alignment of the body, thus better nerve flow, thus better strength to the muscles those nerves go to, and thus better coordination, that equates to better performance, right?
Better balance, yes. Half of the body's weight is the musculoskeletal system. Yet today, it is still one of the most neglected, if not the most neglected system in the body.
Mm-hmm. Okay. So tell us about what type of nerve entrapment can occur, let's say, in a shoulder joint, in the joint itself. I know there's a lot of nerves that run around that joint, right?
Well, when you think of a joint, we could talk about the spine or the shoulder or something. There are different receptors in those areas. There are something called receptors called mechanoreceptors, and there are receptors called nociceptors. Mechanoreceptors sense whether the joint is not moving or whether the joint is moving. Accelerated, decelerated, different types of motion.
Those are impulses that go to the brain to tell you where that joint is, right?
The joint has to communicate to the brain as to the position of the shoulder. And the other receptors we said are nociceptors. Those are pain receptors. So what happens if those mechanoreceptors, because the joints are not functioning properly, if those mechanoreceptors are dysfunctional,
right,
and not working correctly, they will set off those nociceptors or those pain receptors to fire. Once those mechanoreceptors are freed and the proper motion in that joint is retrieved back, it kind of shuts off that pain receptor.
So what happens in a person who has a shoulder injury? I mean, theoretically,
Right.
What would happen in a patient who has a shoulder injury, who has no nociceptor function? They can't feel pain.
Can't feel.
They have no mechanoreceptor functions. Their brain doesn't know where that joint is. How is that shoulder going to work when they try to move it?
It's not going to.
Because the brain doesn't know where that joint is, right?
Yes.
Because the communication has been blocked off, so the brain doesn't know where that joint is and where it has to go to move, right?
Right. And to back up, that's kind of one of the questions that you asked me before. What is really the difference between chiropractic and, say, orthopedic? The orthopedic doctor will look, let's say, at the knee, if the knee is the problem. the chiropractor will look at the whole functional system
Right.
to make sure that there isn't something else relating to cause this problem in the first place.
So on previous shows, I tried to emphasize how important communication is in the realm of healthcare. And as Dr. Lindino just explained, he said that if the brain is not able to receive communication from a part of your body, it can't tell it how to work. Your healthcare team is no different. As I said before, in all of our facilities, our team, which helps you cross that bridge, consists of chiropractors, orthopedists, pain management doctors, neurologists, massage therapists, acupuncturists, psychotherapists. That team has to be able to communicate to one another on a daily basis effectively. If the quarterback, who's in charge of the team, who's given the signals of the place to call, makes the right decisions of what that patient needs, and the team, if they don't communicate with you as the patient, what happens? The body doesn't know what to do. I'll give you a perfect example. What happens if you're going to a physical therapist that is strengthening muscles on the right side of your neck because he feels that those muscles are weak? Let's say now you're going to another chiropractor outside that facility, and that chiropractor and that physical therapist don't talk to each other, and that chiropractor thinks we should strengthen the left side of the neck and weaken the right side of the neck. And then now that patient then goes to a orthopedist who says, no, you need a Botox injection in that tight muscle in that neck because there's so much spasm. We want to put a chemical in there to try to break the spasm. If none of those practitioners are talking to each other, we got one practitioner doing something counterproductive that another practitioner is trying to do, and there's no coordination, there's no communication amongst the team, and what happens? You, the patient, doesn't get better, and you wonder why. You might not ever know why unless your team is communicating on a regular, consistent basis. And that's what our facilities do every day for you, the patient, to benefit the most. Dr. Lindino, do you take care of young people, children, not pediatrics, but children that are playing sports?
Sure,
Do you help them
athletes,
also?
absolutely, sure.
And what kind of injuries do they mostly come in with? Same type?
It depends. If we're talking about, college level, then we're talking pretty much same type. If you're talking, adolescents, if you're talking children, you're going to have some different types of injuries. With children, as you know, they're a lot more elastic. Their bones are even more flexible.
Right.
So the same mechanism of injury on an adult with a child will cause different types of injuries with the children.
Do you ever have children coming in, let's say they're 10, 12 years old, and they're lifting weights, and their parents have them on a weight training regimen? What do you think about that at that young of an age? What's your opinion on that?
Well, I don't have a problem with weight training. It has to be done intelligently. It has to be done to the sense that they don't want to lift, or they shouldn't be lifting too much. They don't want to be lifting their own body weight.
Because what could happen?
Well, they have when you're talking about the younger athlete, you're talking about also the difference between us and them is that they have those growth plates.
Explain to the audience what a growth plate is.
Growth plates are in the bones. That's where the elongation and the development of the bones come from, as far as as they get bigger and bigger. If those are damaged or injured, it can potentially stunt the growth at that area, or even in the whole body with certain things. With some of these younger athletes, when you talk about high schools or colleges, you always hear the term about PEDs and performance-enhancing drugs.
Right.
The danger of that for these younger athletes, especially adolescents, is that it can cause premature closure of those growth plates,
right,
which can result in shorter stature.
How often do we see in our office that we see a patient come in with low back pain, and we do a history on them, and they told us when they were 7 years old they fractured their right leg. And we then go and take x-rays of their lower back, and instead of their pelvis being level, one ilium be the same height and everything being balanced, the patient's pelvis is like this. And we then do a measurement from the top of their leg down to the ground, And lo and behold, we find that the length from one leg to the top to the bottom is less than the other one, because that's the one that's less is the one they injured when they were younger.
Right.
Now, you can go to an ortho, a pain management guy, a surgeon for years and years and years, and treat the pain of that low back. But if you don't balance that foundation and give that patient a lift that goes in their shoe to bring that leg to make it the same length as the other, we're going to continue to have recurrent injury, right?
Correct. Yeah. It's just so distorted that, you know, it's almost like if you have pain in your foot because you have a rock in it.
Right.
You know, you take the foot out of the shoe.
Right.
You give it a cortisone injection.
Right.
Patient feels better. You put their foot back in the shoe with a rock still in there.
It's kind of like how many times have we seen patients who have hurt their knees and they're on crutches for about 4, 5, 6, 7 weeks,
Right.
and then all of a sudden they develop back pain
Yeah, that's right.
because they're limping around. They have an abnormal gait.
Back pain,
That
upper
causes
trap
vertebra
pain,
in the
arm
back
pain,
and the
a
neck
lot
to
of
go out of
different-
position because of that abnormal gait.
Right.
Just like the rock in the shoe, like you just said, or just
Exactly.
like the kid that broke his leg when he was little, and now his whole pelvis is shifted when he gets older, and the patient comes in and says, I never had a car accident that hurt my back. I never had a fall. How could my back be like that?
Right.
And lo and behold, we find out it was set up years ago.
Right, because we are not parts. We are not a head, a shoulder, a
Right.
back, and knee. We are
Right.
one diverse organism, so we have to address everything.
Have you seen young kids come in with elbow injuries, shoulder injuries, Tommy John type injuries because they're trying to throw curveballs too soon or too hard when they're young?
Yeah, sure. I mean, certain sports obviously going to have particular type of injuries. You know, with baseball, wrist, shoulder, elbow injuries many times, especially on the inside of the elbow.
That's from trying to throw curveballs, probably,
It's
right?
overuse, and a lot of times, not taking care of things after they play. You know, icing, stretching, muscle work afterwards, very, very important.
What do you recommend to a father or a mother who's got a son who's 10 years old, and in these leagues they have pitch maxes, so after they hit a certain number of pitches, the coaches have to take them out.
Right.
And they can't pitch them again, usually, depending on the number of pitches they threw for a certain time period.
Right.
What do you recommend for a 10 or a 12-year-old every time after he hits that pitch max after a game? What should he do when he goes home, regardless of whether he has pain or not?
Personally, before he gets home,
Okay.
he should ice that elbow, that shoulder.
Mhm.
Okay. After icing, right after icing is a
For
good
how long,
time.
Dr. Lindino, should he ice it?
20 minutes, no more.
Mhm.
And another mistake, I think a big problem. A lot of times you'll see people icing. I come across this in my practice countless times. They use ice packs or frozen peas or something like that.
Mm-hmm.
It will lose its coldness very quickly. It will not do the job, and they're wasting time, and they're not achieving the benefits.
What
So
should they use?
What I recommend to the patients is a Ziploc bag, preferably a new one, not an old one with a leak in it,
Uh-huh.
and put ice cubes directly into it, and put it directly on the skin for no more than 20 minutes.
Directly on the skin, no
Directly
towel
on
or
the skin.
anything
No,
in between?
directly on the skin, but no more than 20 minutes.
Okay.
And that will decrease that inflammation. Then they can go ahead right after icing, stretch it out a little bit.
Right.
Then they can ice it again later on.
For
you know,
how many
hours
days
later.
or how many hours after an event like that should they do that?
Well, like I said, immediately is always the best.
Right.
If they can do it right away at the ballpark,
Right.
you know, at the field, that's.
Do they do it again the next day, or is
They
it's just
can-
after the game good
They
enough?
could do it again later that night if they wait at least, say, 3 or 4 hours afterwards.
Okay. How many times have you heard in practice, like I have, that a person comes in, oh, I just had a car accident, I hurt my neck, or I slipped and I lifted something heavy, and I went and I took a hot bath,
Right.
or I put a heating pad on I slept on it for 8 hours last night.
Right.
What does that do to that injury? Tell the audience what that
Okay.
physiologically does to an acute injury.
Right. Well, it will, when you think about ice and heat, ice will constrict blood vessels. If the blood vessel is like this, it will constrict it. We want to reduce some of the blood flow at that time and reduce the inflammation. Heat will do the opposite. It will take a blood vessel and dilate it, so you will bring more inflammation into the area, more scar tissue into the area, and it will complicate it for the future.
And it'll actually cause more inflammation the next day. They'll wake up sore than they would have.
Sure.
So it's actually being counterproductive.
Counterproductive, but I hear so many times
All
from
the
my
time.
patients, my neighbor told me to use heat, or this one told me to use ice, or this one.
So basically, I think the rule of thumb that I use for my patients, acute injury, acute doesn't mean it's acute injury. It means a new injury.
Right.
Sorry, no pun intended.
Yeah.
But what it means is that at least for the first 24 to 48 hours, ice.
Correct.
Never put heat
Yes,
on
the
it.
first day or two, maybe even go a third day, you know.
Right. And then thereafter, once the inflammation calms down, the heat may be beneficial to reduce muscle tightness and spasm, and then increase circulation to promote healing, right?
Correct. Yep.
Okay. What sports or activities do you feel lead to the most injuries, sports injuries?
Well, again, it depends on what age group we're talking about.
Let's say a guy who's 45 years old,
A weekend work.
and he plays on the weekends, softball, and he goes out like a warrior out there. What's the most common injury for that?
Then you'll probably see a hamstring pull or tear or a quad pull or tear. Again, you know, when we talk about, and I'll say it over and over again, we talk about balance and alignment. The body must be balanced, not just side to side, but front to back.
Mhm.
When you think of your activities during the day, would you say they are more forward or more backwards?
Forward.
Forward.
Yeah.
So the front muscles of the body, the anterior muscles, the neck, the shoulders, the pelvis, the abdominal muscles, the quads, all these muscles are usually much, much stronger than the posterior muscles.
Right.
You know, when we read something, we don't read like this usually, we read like this. When we're working on the computer, hopefully our head is, you know, pretty straight, but many times when you look at the key, your head is down. The shoulder, we're reaching forward, we're bending forward. So many times there is an inherent weakness in those posterior or muscles in the back, and really technically it should be about a 1-to-1 or 1.3-to-1 ratio front to back. Many times when these people pull their quads or their hamstrings on their legs, it's probably over a 3-to-1 ratio of one muscle being much stronger than the other one.
What muscle is stronger if they're pulling hamstrings?
Usually the quad.
So
Number one, there's 4 of them.
So they're going like crazy doing squats, they're doing leg extensions in the gym,
Even when
and
you
they're
think-
really not exercising their quads as much,
And
their
the
hamstrings as much.
hamstrings, they're not strengthening them as much.
Right.
Think of just your normal daily activities, walking up or down, you know, downstairs.
Right. It's all
The
quads.
quads, stooping down, it's really, you're utilizing your quads so much.
Right.
So that, you know, usually in the older patient, when you're talking about younger patients, like 0 to 9,
Right.
many times you're talking about, believe it or not, bicycle, or at the playground. Those are the
What
type
kind of
activities.
injuries from bicycles usually with young children?
A lot of times head,
Head,
you know,
neck?
head, neck, sure. And then when you get to like the 10 to 20 range, then you're talking more, you know, more sports like football, basketball,
Mhm.
things like that. But even bicycle, even at that age,
What's
is
your
still up there.
what's your most common football injury you see in your office?
The most common football injuries are usually ankle, knee, thigh,
Yeah.
shoulder, and neck usually.
Yeah. In my experience, I find that knee far blows away with football,
Yeah.
because can you pass that to me
Sure.
for a minute? So, because now you've got a knee structure. Let me just explain to the audience on camera. Now we've got a knee structure where the foot is down here, it's planted on the ground, and now they have an opposing player coming toward them, and they have to make a quick cut to avoid that player. Foot is planted down here, and when they make a quick cut, that's going to happen to the knee joint. It's going to torque, it's going to twist, it's going to stress all the ligaments that are inside there. And in a sport like football or lacrosse, where you really can't predict or plan your movements as well as other sports like track, where you can know where your leg's
Right.
going to go the next movement. These sports like football, they're reflex movements. You don't even think about them. They happen automatically without you, just to avoid a collision, and your limbs could be in many different positions as a result, right?
Yeah. Plus, think of the conditions of the field today. Are the fields grass today, or are they of different surfaces today that they use?
So, Dr. Landito, I'm going to touch now on a very controversial topic.
Yeah.
In all sports,
Yeah.
from high school, maybe even junior high school, up to professional athletes. And that's the problems sports chiropractors and orthopedists find as a result of steroid abuse.
Yeah.
So when somebody's taking steroids and it's a chemical that makes muscles get bigger and stronger at a faster rate than they normally would, what effect does that have on the ligaments, on the cartilage, on the supporting structures that can be injured and torn as a result of that drug use?
Well, it weakens them.
How does it weaken them? It actually makes the tissues not as strong, like the ligaments become less strong or the cartilage becomes less strong.
Well, and the muscle in general also, when you think of the heart tissue, many times, with steroid use, it also affects the blood vessels. It causes calcifications in the blood vessels that can lead to future heart issues and heart problems.
Right. So I think what I've found in my practice when I have athletes coming in on steroid drugs to become stronger is that many times the trainers or themselves,
They put more wear and tear on.
they don't
them,
work
obviously.
on endurance first along with strength. So in other words, if you now have a quadricep muscle that was this big before you started a year program of heavy lifting, exercise lifting, and supplementation with growth enhancing drugs, the muscle now doubles its size, but the end of the muscle, the tendon where it attaches to the bone, that really hasn't had a chance to become tougher and stronger in its attachment to catch up with the muscle.
And most of the injuries are at that area.
Exactly.
Usually at the
So
muscle
now
tendon
now
or
you've got a
tendon
big
bone.
muscle, the end of which is a tendon about the size of my finger attaching to a bone. That tendon is attached to the outside of the bone, and now that muscle up here contracts so hard that that tendon can't stay attached to that bone because they haven't done conditioning training to make those tendons stronger. And a lot of really good trainers, before they'll even consider strength training for professional sports, they'll make sure their endurance training is at its max first, so they have very strong tendons and ligaments before they now put that extra stress. Do you agree with that, Dr.
Yeah,
Lendio?
I do agree with that.
Okay, so let's talk about male versus female in sports injuries. Is there a difference between gender as far as incidence of sports injuries?
The differences usually between males and females. Females, when we were talking about the growth plates earlier,
Right.
female growth plates will usually close a year or so before male growth plates. As far as the types of sports, you're not going to see football as much with younger athletes for women or young women. But soccer you're going to see, and again, it all depends on the sport. So you're going to see more knee, ankle type of injuries, especially with soccer. Also heading the ball, which is not good in the long run.
That's
Like a concussive force over and over again. And playing sports, when I was younger, you didn't want to drink as much during the game because you didn't want to have the urge to urinate. You wanted to focus and concentrate, and not have any distractions.
That's how you were taught?
The
when you were
problem,
younger?
well, you know that you're supposed to
Right.
drink before and during and after.
Right.
But especially with women, especially when you're talking about soccer in general, when they head the ball and they don't drink enough water, a lot of times that can be even more traumatic to the brain without that water cushioning.
Really? Interesting.
And also, when you talk about particular sports, maybe with women like gymnastics or ballet or, particular sports like that, they also have to, a lot of times they worry about their fat content. They want to keep their weight down.
Right.
A woman needs between 12 to 14% fat to produce estrogen. Otherwise, it will affect their menstrual cycle. The
Right.
long-term effect of that and danger of that for women, young women, is that it can cause premature osteoporosis.
Again, that's bone loss.
Bone loss, correct. Decreased bone loss.
So I think we sometimes see that in these marathon athletes, the women, right, where they go into premenopause,
Exactly.
and now they have bone things that can happen to them.
Exactly.
Very good. Well, Dr. Lindino, I'd like to thank you again
Thank you
for
so much
joining
for
us,
having
and
me.
I
It's been my
I
pleasure.
hope you come back again
Thank you.
to a future show. And once again, audience, I want to thank you for watching us. And if what you're interested in is real wealth, join us next time on the Bridge to Health.